Chapter 6, Implementation and Evaluation. Okay, so we said the implementation phase of the nursing process is the phase in which the plan is put into action. So you're carrying out your orders, you're carrying out your interventions. The nurse may be involved in providing direct care or may delegate care to other members of the healthcare team. So you, as the LPN, can delegate to unlicensed assisted personnel. So that could be the nursing assistant. That could be, um, other unlicensed assisted personnel, secretary or housekeeping. As the LPN, you can delegate to unlicensed assisted personnel. Sometimes in long-term care facilities, LPNs might be the charge nurse, so you might delegate to other LPNs as well. Written documentation of activities that occur during implementation should be you could put those in the nursing diagnoses. I'm sorry, in the nurse's notes. You can put it on flow sheets, or you can put it in the nursing care plan. Um, so you should be writing whatever intervention you've um, implemented. Um, at minimum, at least verbal communication of what you've implemented during handoff report. So if you're handing off to another healthcare team member, such as an shift report or something like that, or transferring a patient to another unit or something like that. So we've talked about priority setting quite a bit. You're going to have to prioritize um, your nursing interventions. And so your priorities will constantly change. Just because your priorities is one thing at the beginning of the shift, if a patient's condition changes or something and they become more ill, more acute or whatnot, then your priorities very well may change. But like we said, when you're prioritizing your workload, so what interventions you have to do, um, you want to take into consideration, are they having visitors coming? Do they have diagnostic tests scheduled? Do they have surgery scheduled? Is the physician going to be making rounds? Um, what time do you have to administer medications? So all those things can take a, a should be taken into consideration when you're setting your priorities on how you're going to implement your interventions. You have some time fixed tasks and you have some time flexible tasks. So time fixed tasks are things that must be done at a set time. So, for instance, your medication administration. If a patient's medication is due at 9 a.m., that's time fixed because you may have a window, whether it be 30 minutes before, 30 minutes after, or hour before, hour after, whatever. You have a set time that you have to get that done. That's time fixed. Whereas time flexible can be done anytime during your shift. For example, a lot of times your dressing changes will say um, complete the dressing change on day shift. So if you're working day shift, you have all the day shift to get that dressing change done. You just have to get it done within your shift. And so that would be considered a time flexible um, task as you're setting your priorities. So before implementing any intervention, like we've said, even when we pass the medications, whatever it is, whatever the intervention is, you want to first, make sure you have your physician order and you've checked that. So make sure you understand the reason for the intervention. What's the rationale or whatnot? What's the usual standard of care? Um, Maybe you need to check the facility's policy or whatnot on what's the standard of care on how to perform that intervention. If it's the skill that you've never performed before, don't think. A lot of times, new nurses may think, oh, I'm a nurse now and they're expecting me to know certain things. And so I should go and try to do this by myself. No, that is not the case. If you've never done something before, don't go in there as if you're a super nurse. Go get your supervisor, go get an experienced nurse or somebody to go in with you to perform that task with you until you're comfortable with it because you don't want to just go in not really knowing what you're doing. You want to make sure you understand what the expected outcomes of this intervention are, so that when I go back to reassess to determine if my outcomes were met, um, I know that, right? What are the potential dangers of this intervention, right? And so we've talked about um, you have independent, dependent, and interdependent um, nur- nursing actions. And so your independent, remember, don't need a physician's order, whereas your dependent requires a physician's order. So, like passing meds or doing a treatment or something like that would require a physician's order. And then your interdependent are come from collaborative care planning. So maybe collaborating with the therapist and whatnot to perform interventions for your patient. So some healthcare institutions actually use interdisciplinary care plans. And so with interdisciplinary care plans, they're going to combine the efforts of the entire healthcare team into a care plan versus having a care plan for nursing with set nursing goals, then a care plan for dietary with set dietary goals, and then a separate therapy care plan with therapy goals. No, it's going to be um, one care plan that combines all the disciplines um, input so that everybody's working toward the same goals. And the patient, again, should be included in setting those goals. So we're all working towards the same goals and no one's having, trying to achieve different goals and things like that. So when you have these standardized um, protocols or care plans like that, and you can have the experience of all the disciplines helping to contribute to the patient's improving or reaching their optimum level of functioning. And so you can also learn from other disciplines as well. It's a collaborative effort. You can learn different things from other disciplines as well. Okay, when implementing care, um, employees and students are expected to perform at a standard of care that's listed in the procedure manual. And so this will help to ensure efficiency. Um, and so in your book on page 78, um, that is box 6.2, it lists out the standards of steps um, that should be followed when performing nursing procedures. So step A, perform the task according to the protocol. Step B, check the order, collect the equipment and supplies, and perform hand hygiene. Step C, identify and prepare the patient. Remember, you got to use your two identifiers. Um, Step D, provide privacy and institute safety precautions, arrange the supplies and equipment. Step E, use standard precautions and aseptic technique as appropriate. So standard precautions are precautions that should be used on everybody. We're treating everybody as if they're infectious. So if we have the potential to come in contact with blood or body fluids, we wear the proper PPE. Um, Gloves, if we think it could get on our clothes, a gown, if we think it's could splash, we could do goggles and things like that. So standard precautions should be used on everybody. We're treating everybody as if they're infected. Step X, remove gloves and other protective equipment. Step Y, restore the unit, collect the used equipment, dispose of, clean, and store items in the proper places. And step Z, record and report the procedure. So we said some of the tasks you can delegate to unlicensed assisted personnel. So nursing assistants, you can delegate to nursing assistants. So what things can you delegate to nursing assistants? You can delegate routine basic care on stable patients. So patients that are stable, we can delegate routine basic care. So we need to understand, first of all, when we're delegating, we need to understand what the law says that individual can do based on their level of education, and then what your facility says a patient can do. Um, Now, a facility can make stricter rules than what the law says. They can't loosen them, but they can make them stricter. For example, the law says a nursing assistant can do vital signs, perform vital signs on stable patients. However, all facilities don't necessarily allow their nursing students to uh, uh, perform vital signs. So we need to know what our facility says in addition to what the law says the person can do. We want to make sure they're stable. Now, for example, when we say stable, um, if they just got out of surgery, they're probably not stable yet. Now, for another instance, a patient that has dysphagia, which is difficulty swallowing, we won't want to delegate because a patient we can delegate feeding to an aide. However, if that patient has dysphagia, they're not stable because they could aspirate. And so we wouldn't want to delegate that patient to an aide because they're not considered stable. So, just like I said, your basic routine care, feeding, not dysphagia patients, um, range of motion, turning, toileting, ambulate and stable patients, things like that. They can, your basic care. Medications always have to be done by the LPN. So you can't delegate um, an aide to uh, administer a medication. You shouldn't even be delegating the aide to put creams on a patient either because that is considered a medication. You shouldn't be delegating invasive procedures or sterile procedures or things like that. The aide cannot do that. The nurse has to, if you have to put in a Foley, it has to be the nurse. If, trach care, things like that, you can't delegate invasive things. So only basic routine care for stable, patients. And also, don't when you answer these questions, don't look at, well, what if they're medication certified, or what if. No, it's no what if. We're not adding to it. And so, if it just says nursing assistant or unlicensed assisted personnel, that's just what it is. We're not saying what if anything. Don't, add that into your questions. Okay, sometimes in home health care also, nurses might be visiting patients for a variety of reasons. Maybe so if you're doing home health care as a nurse, the patient has to have some type of skilled need. Maybe they need education on their meds, help administering their meds, changing dressings, performing therapy, or performing different, treatments and things like that, or maybe we're teaching the family how to do these things. Remember though, if you as the nurse go out, you're doing catheter care, trach care, things like that, or whatever. Those are things that require sterile technique. So you as the nurse will always perform sterile technique. However, if a patient is doing something, maybe they're doing self-cathing themselves at home, they're going to use clean technique on themselves. If they're doing self-cathing themselves, they'll do clean technique. But if you were the nurse going out there, you always use sterile procedures for invasive um, procedures. So you want to always make sure you document your interventions, whatever intervention. After you've performed it, you don't document before, you document after you performed it. So maybe you administered a med, maybe you did a dressing change, maybe you checked vital signs, whatever your intervention was, you always want to make sure you document your intervention. If it wasn't written, it wasn't done. So you have to document to show that you've done something. If, say, for instance, if you don't document a medication or something, then maybe the person had a PRN, which is as needed medication. You didn't document that you gave it. Then the next person comes along and says, "Oh, this person hasn't had this medication in 24 hours. Let me give it to them." And you just gave it to them 10 minutes ago, but you didn't document it. So now they've gotten too much of the medication. Or you didn't document vital signs. Then we can't see that there's a drastic change in their vital signs or their health status or different things like that. So it's important that we document whatever interventions we perform. If it wasn't written, it wasn't done. Question one. During the implementation of the nursing process, the answer is one. So during the implementation of the nursing process, the planned nursing interventions are carried out, such as administering pain medications for a patient that's in pain or something like that. Question two. Before Mrs. Bricker, an LPN, carries out any intervention such as the administration of medication, she must know what? The answer here is five, all of the above. So before carrying out any interventions, a nurse must know the reason, the standard of care, the expected outcome, and any potential dangers. Question three. After Mrs. Bricker, who's an LPN, has given her patient medication, she returns later to the patient's room to evaluate the effectiveness of the medication. She knows that in the evaluation phase of the nursing process. The answer is three. So if the expected outcomes are considered met, the nurse's note must contain data to support this finding. And so the evaluation process is a continual process. Ineffective interventions must be revised. If the goals aren't met, reassessment must be performed to determine what goals would be appropriate. So we said evaluation, the fifth phase of the nursing process being evaluation. And so that's a determination of the effectiveness of the care plan. So were the interventions effective in achieving the patient's goals or outcomes, expected outcomes. So don't forget to include the patient in the evaluation process as well. Just like we got to include them when developing the goals, we need to include them in evaluation. Do they feel they met their goals to a satisfactory level as well? So we have to, in the evaluation process, we're going to evaluate to determine if our goals or expected outcomes were met. If the goals were not met or achieved, then we need to A, look at our goals again to determine were the goals too lofty and do we need to reevaluate our goals or add new goals or whatever. Or B, do we just need to change? We need to keep those same goals, but um, change our interventions and come up with some new interventions to help us reach those reach our goals. And so understand that the evaluation process is a continuous process. We should be constantly evaluating and changing and updating, um, you know, updating our goals as needed. If the patient worsens, then we definitely probably need to add some new goals and interventions to that care plan as well if they're getting worse. Okay, so quality improvement. So quality improvement is an agency-wide evaluation of care that's delivered by all departments. And so you audit the processes. You're looking at your current processes and determining are they effective or do we need to change our processes. For instance, does this area have a high um, infection rate? Does this unit have an increased number of falls? Are there a lot of medication errors? So we're evaluating our current processes and determining how if they're effective or not, or do we need to put some new processes in place. So every agency should be doing quality improvement techniques to just improve their overall patient care and the care that they're providing to patients. Question 4. Does Debbie, a student nurse, is learning about care plans. She knows all of the following are true regarding care plans except the answer is 3. An LPN um, may construct a care plan, a preliminary care plan in a long-term care setting. However, a RN has to review and sign, modify it as needed, and then sign it before it can be finalized and put in the chart. Otherwise, most settings, your RN is going to be the one that does that constructs that care plan. Okay, question 5. Flora, an LPN, is helping her patient understand the side effects of a medication. This is what type of action? It's going to be 1, independent action, because it doesn't require a physician's order. The nurse can, explain the side effects of a medication without having a physician's order. Um, but it does require critical thinking and nursing judgment.